All right. Everyone knows I'm Jason. About ACLS this morning. Okay. Similar to the way that this has been on for the rest of the month. This morning is going to be kind of like drinking from a fire hose. Okay. If you have questions, it's not that I don't like answering them. It's that I have a certain amount of content I have to get through in the next about 20 minutes in order to get you guys to the OR on time. So I'm mostly just going to throw stuff at you. And then we're going to have a long session this afternoon, which we're going to go PBLD, and I'm going to be able to answer all the questions you guys have, okay? That's going to be the deal, all right? I have no disclosures. We put these on every lecture because you can't count CME if you didn't. If somebody came in wanting CME, you wouldn't be able to, okay? So we're going to overview ACLS, which comes down to pushing a chest, pushing a drug, and maybe pushing a button or shocking somebody, okay? And really ACLS applies to the operating room and the anesthesiologist, and are somewhat unique H's and T's, and our considerations when arriving to a code, okay? And then we're going to go over some case scenarios this afternoon. Okay. The key principles with ACLS, probably the most important key principle, is just assume the worst for the patient. If you're thinking code, assume the worst and prove that you're wrong, okay? If you are wrong and you start pushing on someone's chest and the patient says, "Why are you touching me?" they're probably okay, okay? And you can probably stop worrying. If you're not wrong, start ACLS immediately, meaning there's no pulse, okay? If you don't know, do BLS until proven otherwise, okay? Everyone knows Dr. Adrian Hendricks. I call this a Hendricksism because he taught me that exact phrase when I was a CA2, and it bored itself into my skull, okay? BLS until proven otherwise. If you are wrong about the patient's status being a code, but they're maybe unstable, monitor and treat any decompensation as needed. The goal being avoiding the worst or avoiding the code. Okay, and always, always, always call for help. Okay, so what's BLS? Let's break it down as best as we can. Okay, so first thing is always assure scene safety, meaning don't go in and help somebody when there's an active bomb that's next to them that might blow up. You're not going to be able to help them. You can't help it. Anybody see the fire on the way in this morning? It's a big fire just off of Colfax, maybe 5 blocks from Peoria. Call for help, okay? Assess the patient's level of consciousness. Call for help. Assess their pulse and their breathing quickly and simultaneously, okay? And regardless, call for help. Not sure if there's a pulse or breathing? Then there is no pulse or breathing. If you're not sure, then there's not. Just assume that there's not. And again, assume the worst. The patient will tell you if you're wrong, okay? Oh, and remember to call for help, okay? No pulse, start chest compressions. No breathing, start airway management. That's ACLS, okay? That's where we come in as experts in resuscitation, okay? So before we get into the whole algorithm, anyone tell me, this is the little bit of interactive here, what are the only 2 components of ACLS that are based on reasonably strong evidence?
Compressions first.
Compressions, high quality chest compressions, okay, and early shocking when shocking is advised. Okay? Those are the only things that actually improve outcome. There is actually one other thing. Okay, what about the drugs though? Are the drugs evidence-based, the doses and the drugs that we used? They're actually not. Find me one piece of evidence that says 1 milligram of epinephrine is the right dose in the ACLS. It doesn't exist. Okay? It really doesn't. It's all historic, and we use it because we know that it just happens to work. We also know that we cause quite a bit of cardiac stunning and cardiac injury by giving such large doses of these medications. The goal being just get them back, get ROSC, and we'll worry about the other stuff on the other end. You can't kill a dead person, is the old adage, okay? What did the 2015 update do by comparison to all the previous updates? Anyone know?
Early compressions.
Yeah, so it has to do with compressions, but it has to do with end-tidal CO2 monitoring in terms of compressions, okay? And we'll get to why that's important. And lastly, who and when can the ACL, who can modify it and when can the ACLS algorithm be modified? Give you a hint. Okay. The second that every one of you has graduated from residency, you become an expert anesthesiologist, and you fall in the category of someone who is an expert in resuscitation. They'll argue that very early in your residency, you'll actually be more of an expert in resuscitation than a lot of the physicians in this hospital. Okay, and as a result, we modify this algorithm regularly and almost never follow the algorithm exactly as it is. Okay, so this is the picture that everyone's used to, the classic ACLS cycle. Okay, start CPR and go around. Okay. We summarize the algorithm. It essentially comes down to this. No pulse, start CPR with high-quality chest compressions, oxygen, and applying monitors and pads. Does the patient have VFib or pulseless VTAC? Shock them. Okay? Either way, whether you shock them or not, you get them IV IO access as soon as possible, give them 1 milligram of epi, consider an advanced airway, monitor the quality of CPR. Okay? 2 minutes. Regardless of whether you shock them. If you shock somebody who is in pulseless VTAC, that doesn't mean they're going to have a heart rate back. This isn't television, okay? They might have an electrical rhythm back, but they're not going to have a perfusing rhythm back. So you push on them until they literally tell you, stop pushing on me, or 2 minutes have gone by and you do another rhythm and pulse check, okay? Then did you get return of spontaneous circulation? Okay, then we're going to move on to post-CPR management, okay? So, again, you guys should know this as part of being ACL certified, most of you. But CPR quality begins with 2 inches of chest compressions, okay, at 100 to 120 a minute. Okay, you've got to allow complete recoil in that. Okay? Minimizing eruptions, avoiding harmful maneuvers such as overventilation. Okay, we ventilate in a 30-to-2 ratio still when we don't have an advanced airway. And about 10 breaths a minute, or every 6 seconds when we do have an advanced airway in place, okay? We're lucky in the operating room in that we have an end-tidal CO2 monitor, okay? And an end-tidal CO2 less than 10 indicates a very clear need to improve the quality of your chest compressions, either the rate or the depth or allowing more recoil, okay? And rather than looking at the actual rate, what we'll do in the operating room is look at the end tidal in somebody who's getting chest compressions and say push harder, push faster, whatever, instead of just follow the what's the song that everyone uses? Staying Alive. Yeah, great. Okay. If you have an art line, great. A low diastolic blood pressure can alert a need to improve CPR quality as well, okay, because that pulse pressure widens, and it may also indicate a need to give more vasoconstrictor, or simply epinephrine, right, which we more often titrate in the operating room than giving just 1 milligram of epi every once in a while. In a true code, we'll still give 1 milligram doses, but I can literally count on one hand the number of times I've done that I've actually never had to do it in my own cases, but in helping people in cases before. Okay? If the rhythm's shockable, we're still using 120 to 200 joules biphasic or 360 monophasic. And if it's refractory, we're still doing amiodarone, just like you would have learned in ACLS. Okay? All right. So the end-tidal CO2 monitor, our line, and pulse oximeter deserve another special mention. Okay? So Harley and Andrew know this because I harped on it our first day, but what is the end-tidal CO2 monitor to an anesthesiologist? Is it an airway confirmation monitor to an anesthesiologist? No, it's not. It is. It's great. We're all happy that the endotracheal tube went in. But if the end tidal goes from 35 to 25, what does that tell me? It doesn't tell me the endotracheal tube fell out, right? What does it tell me?
Cardiac output.
Yeah, it's a cardiac output monitor. Okay, the end-tidal CO2 is a cardiac output monitor. So, as such, that's why it's correlative with high-quality chest compressions, because you're looking at the cardiac output that you're administering the patient, okay? And it's been found that an end-tidal CO2 less than 10 at 20 minutes of ACLS is correlative with a 100% failure in return of spontaneous circulation. Meaning if you're giving high-quality chest compressions at 20 minutes and you're not getting any more back than an entitled of 10, that patient is dead, meaning they're not metabolizing anymore, right? They're not actually producing enough CO2 that they can live. Counter to that, an entitled CO2 greater than 20 is correlated with markedly improved outcomes. Okay, so our goal is greater than 10, but our real goal is greater than 20 or even just normal, because our goal is normal cardiac output, right? That's the whole point of chest compressions. Okay, so the pulse ox and the art line, why are they so important? It says it in the first word of the first monitor. It's P word. Pulse, right? So think about the old days of anesthesia when they had to look over the drape to see whether the aorta was bouncing or whether there was arterial blood flow, or they had to reach down and feel the carotid artery. We have a continuous sign on the monitor that the patient has a pulse. Okay, we always know they have a pulse. We don't even need to look at the monitor. We can just hear it, right? So in the operating room, we're a lot better at not reaching codes, but reaching what people would consider pericodes, or situations of hypotension, like we had yesterday, right? We had a severe bradycardia event in our case yesterday, and you recognize that and you treat it early, never having to actually give or move into a true ACLS algorithm. Okay? Make sense? All right. So this is just reiterating what we've already seen, okay? CPR is in 2-minute cycles. We're going to switch CPR providers, okay? In the OR, a code is an anesthesia stat, okay? If you hear an anesthesia stat, that's essentially a code or such a bad airway experience that we just can't get a control of it. It's going to become a code, and you end up with a line of people ready to do chest compressions, okay? Which is what you need. You check if the rhythm shockable, get IV access if you don't have it, give epi every 3 to 5 minutes, consider an advanced airway, although we do advanced airways even while chest compressions are going on. That's because we're advanced airway providers, okay? Us and ENT essentially are the ones that are allowed to do that, okay? That's why we get called to every code at this hospital. At every major center, anesthesiologists go through every single code so that they don't have to interrupt chest compressions, because interrupting chest compressions is correlated with poor outcomes, okay? So I do all my intubations at codes. Just keep pushing. I'll get it in. It's fine. Okay. VFib, VTAC, shock ASAP, shock every 2 minutes, and amio if you've done 2 to 3 shocks or more in the refractory. Okay. All right. So now you have return to spontaneous circulation. What's this patient? What's your job with this patient? Well, it's to optimize their oxygen onloading and their CO2 offloading. Give any prescription for hypotension you need to, whether that be fluid or vasopressors, whatever is going to actually treat what their pathology was. If they had a code because they bled out, give them blood, okay? Give them vasopressors to keep perfusion going until you get them resuscitated, but you treat the problem, okay? Get a 12 lead, see whether or not they have any reperfusion injury, discuss with ICU whether or not this patient might meet criteria for cooling, and always advance to expert care. We are expert care, and our ICU guys within our department are even next level expert care, okay? And they can help us a lot with the post ROSC, post return of spontaneous circulation. If I had a code, I would always call one of our ICU colleagues and say, hey, this happened, I got it back, but what would you do in this setting? Okay. and diagnose and treat H's and T's as appropriate. Okay, so tachycardia, hypotension, low SpO2, high airway pressures in the setting of an upper abdominal procedure. What does that seem like to you? Yeah, it's a tension pneumothorax until proven otherwise. Okay, so haven't put any chest tube in. You got a surgeon right there. They can put a chest tube in 10 seconds if they need to in the setting of a tension. Right. Worst comes to worst, they just stick a big needle through the chest and then they can fix it with a chest tube later. Okay. But take advantage of the fact that you have a surgeon in the operating room. Okay. So this is another breakdown of the H's and T's and post-ROSC. Okay. And a couple special peri-op / anesthesia ACLS considerations are H's and T's, as it were. High neuraxial, spinal, or epidural. Okay, you guys learned about neuraxial anesthesia yesterday. Remarkably safe. I told these guys I would choose neuraxial anesthesia if it was at all an option for me for any procedure. In fact, I'd choose it without any sedation if that was an option. That doesn't mean that neuraxial anesthesia is not dangerous. In fact, it's remarkably dangerous. And a high spinal is one of the ways that we actually end up killing people as an anesthesiologist still, okay, if it's unrecognized. Drugs, anaphylaxis is a very real thing, okay, whether it's Sugammadex or rocuronium or Sux, those are the common players that we have now. It's not Ansef that's going to be your most likely. It's not latex that's going to be your most likely, okay? We've had anaphylaxis to chloroprep in the last year here, okay? And let's see, local anesthetic systemic toxicity is its own big topic, but has its own ACLS algorithm that we designed. You know what you don't do in it? The key thing that you don't do is you don't push a milligram of epi, okay? You push much, much smaller doses of epi, okay? Because the outcomes are a lot worse if you push a milligram of epi. And then marked anesthetic overdose. Lost airway is obvious. And then obstetric patients and bad patients both have very specific algorithms that we need to go through as well. Obstetric patients don't actually differ all that much. There's just a couple other considerations you need to go through. And bad patients don't push on their chest unless a CT surgeon is present because you will dislodge the device and then they'll just bleed out from their heart. That's not ideal. Okay. What about the patient that isn't coding? Specifically, the bradycardia and tachycardia algorithms. Okay. This is very quick. Okay. Key points is this is bradycardia with a pulse. Okay. With a pulse, like we had yesterday, right? But she wasn't actually that unstable because I could see on her end tidal that her end tidal was basically stable. So her perfusion was fine, even though her heart rate was 32, right? So we didn't move to pushing the med that we're going to talk about on the next slide, okay? We assessed her condition, okay? We thought BLS, 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 and we said, okay, is there any sign of malperfusion here? Well, maybe, but let's treat it as we need it, okay? The first step the non-experts do under all circumstances with unstable bradycardia is atropine, okay? A 0.5 milligram, repeat every 3 to 5 minutes with a max of 3 milligrams. Okay? That is a lot of atropine, and you deal with a lot of tachycardia for a long time after you give atropine, and then you deal with delirium for an even longer time after you give atropine. So, for the most part, we don't like to give it. We also have glycopyrrolate, which is like atropine light, and it also doesn't act centrally, okay? So, my go-to typically with any sort of unstable bradycardia that's not really causing true malperfusion yet is I'll give some glyco and or ephedrine. And if I really am moving towards a problem, I'll actually move to epinephrine earlier in low doses of epinephrine. We are the only service in the entire hospital that pushes 10 mic boluses of epinephrine. They don't even do that in the ICU. Okay, they start people on epi drips, which is why these algorithms exist. It goes atropine, pacing, dopamine, or epinephrine. Okay, so atropine might not work in some types of unstable bradycardia, right? Such as complete heart block. Right? Atropine's not going to do anything, right? It can be great at increasing your atrial rate, but that's not going to do anything to your ventricular rate, right? So, in that patient, you're almost definitely going to have to move to transcutaneous pacing. Okay, that hurts. So in an awake patient, you got to sedate them a little bit. Luckily, most of our patients are nice and sleepy already, and we can just pace them away. Great. Okay. Beyond that, consider expert consultation and even transvenous pacing. I don't know how to put in transvenous wires, but there are a number of people in our department that do, and this is where calling for help comes in. Okay? You call for help if you don't know how to do it. Great. Right? That's every anesthesia algorithm that ever exists. Okay? I harped on you guys. The difficult airway algorithm, every step along the way is call for help, call for help, call for help, call for help. That's how we keep ourselves out of trouble as anesthesiologists. All right? So, things that might cause bradycardia in the periop, anorexia, vagal stimulation, abdominal visceral traction, insufflation, different types of reflexes, okay? Or even airway stimulation. As much as it can cause tachycardia, it can also cause bradycardia, okay? One of the most refractory, repeat, vagal stimulating bradycardias I've ever seen was in an airway room, where every time they DL'd, this woman just bradyed down to the 20s. And I let go, and she came right back up. Bradyed down to the 20s, came right back up. I ended up giving her like 1.5 of glyco, like a ton of glyco before it stopped happening. And then she was like tachycardic for 2 hours in the PACU. It was like super not fun, but it was what we had to do to get through the case. Hypoxia, once it's severe, and especially in peds or neonates, certainly can cause bradycardia. Okay, and then drug overdose, which is what we saw yesterday. Okay, a little bit too much remifentanil in somebody who wasn't getting stimulated. Okay, and just too much for her. It was actually a pretty low dose. But that's the thing, is every patient's individual, right? So you don't know what's actually going to affect one person versus another person. So keep in mind that opioids, beta blockers, alpha-1 agonists, alpha-2 agonists, anticholinesterases, and local anesthetics can all cause bradycardia. Okay? So the tachycardia algorithm is probably the most complex of all the algorithms, okay? Because there's all these offshoots, and then there's like, but if you do this, but if this is happening, blah, 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 blah. So if you want to make it simple on yourself, if you're any concerned at all that there's malperfusion, shock. Okay, there's nothing wrong with shocking. Okay, I did this on the floor a week and a half ago, and somebody that was in unstable VTAC, but actually kind of awake, but they were unstable. Okay, and then you just have to remember what your JUL numbers are based on the thing. Adenosine is a perfectly acceptable choice in narrow regular rhythms, okay? And then beyond that, it gets a little bit more complex, okay? In wide complex rhythms, adenosine's fine, okay? You consider other antiarrhythmics if it's not regular, okay? And in narrow rhythms, vagal maneuvers, beta blockers, calcium channel blockers are all great as long as the patient's perfusing relatively well. And you can use adenosine as well if you want to get them out of it. Okay.
Quick question.
Yeah.
Pulses VTAC, you just shock if you're defibrillate, and then with VTAC you do like cardioversion.
Yes, exactly. So synchronized cardioversion if they are pulse having, not pulseless. If they're pulseless, then you just defibrillate them. Okay. Just boom, high level, and I go straight to max joules. If I'm defibrillating somebody, I just don't mess around because I just want them out of it. Because, like I said at the start, the only thing that's been correlated is early shocking with success, right? And high quality chest compressions. Get them out of the rhythm, okay? And what is the point of shocking somebody? What does it actually do?
Resets the SA node.
Yeah, so what is actually going to happen on the EKG? Yeah, they're going to go into asystole, right? So they're going to go into asystole, and they're hopefully going to reset their SA node and then go back into a normal rhythm, okay? Or go into whatever atrial rhythm they need to go into, okay? If they go into a heart block rhythm, again, you might be happy that you have those pads on already because you might need to move into a transcutaneous pacing mode, okay? That does happen. All right, as far as tachycardia in the periop and anesthesia world. Neuraxial. Anyone seeing a trend here? Okay, Neuraxial is my realm, and it's literally on every single slide as a potential cause. Okay, because it's dangerous if you don't know what you're doing. It's remarkably safe if you do know what you're doing. Okay, hypovolemia, hemorrhage, embolism, airway stimulation, pain, and then, not surprisingly, drugs. Right, anticholinergics, vasodilators, sympathomimetics, and general anesthetics. Anyone know which specific volatile anesthetic is most likely to cause tachycardia? Desflurane, my least favorite anesthetic. Okay? If you work with me, you will not use desflurane. I'll tell you that right now. Okay? Cool. See you in the afternoon. Go do your cases.